All right, so I've entitled my talk, My Take on Hipec. As Dr. Sugarbaker said several times last night, and I think he's probably said several thousand times in his career, the people that he has the hardest time convincing sometimes are the medical oncologists. And so I'm here not as a contrarian, but as someone who tries to take a little more dispassionate look at some of these issues. I'm also older than some of you, and I've been doing this for a while. I've been in oncology for 30 years. And so I think in general, I've learned a little bit because of the time that I've gotten over that period of time. I think a couple of basic concepts are, number one, we have to be honest, and not to say that anybody in the room is dishonest, but I think we have to be very careful about making sure that we look at things in a dispassionate way sometimes. I also think we have to think outside the box. I think one of the criticisms I have of my own colleagues in medical oncology is that we're sometimes too rigid, and thinking outside the box is something Dr. Sugarbaker's pretty good at. So I'd like to kind of include both of those concepts in this discussion. Now, Dr. Sugarbaker said I was going to present you with all kinds of data. In fact, I'm not. I have a little bit of data, but what I thought I would do is, there's a lot of data in Hipec. The problem is that a lot of data is, as he mentioned, small studies, individual institutional experiences, and that's not what medical oncologists typically use as our decision point. So just to kind of review my objectives, I only have about 20 minutes, but I'll go through it quickly. So I really want you to understand my concept of treatment of intra-abdominal, intraperitoneal malignancies. I'd like to illustrate my own struggle professionally in determining a specific role for Hipec within the kind of broader context of these diseases and for which conditions. And I'd like to understand a little bit how I attempt to integrate systemic therapy with this again, and I'm not going to go into a great deal of detail, but it's more of a conceptual talk. So just briefly to review, what do we have available? I know there's a lot of non-medical people in the audience, non-medical from the professional side, but very medical from the standpoint of people who've been impacted by these things. But from the surgery side, we have so many moving parts. We have minimally invasive therapy, we have robotic surgeries, we have a lot of things that are changing. One of the problems we have with measuring all these issues is the fact that when you have 47 variables, it's very hard to figure out which variable is the one that impacted a specific issue. With chemotherapy, things are changing dramatically. When I was a fellow, there was typically one new chemotherapy drug every 5 to 10 years. Now we had 14 FDA approvals last year for new medications, and it's really important to figure out how to integrate all these. We just had a new drug, for example, for colon cancer approved last week, TAS 102, which is a new drug that showed a positive survival advantage in a paper that was published in May in the New England Journal of Medicine. We have variable radiation. I mean, again, in the last 5 years, what we're doing now is stereotactic body radiation. We're doing embolizing radiation microparticles with Y90. There's a lot of other options that we have. And really, I think the treatment of the future is going to be immunotherapy. So the big thing right now in multiple malignancies is the onset of use of adoptive immunotherapy and all of the checkpoint inhibitors, which are now being approved for melanoma, for kidney cancer, soon for bladder cancer, currently for lung cancer, and it's going to be a broad-based impact. In GI cancer, we're expecting that we're going to see some positive data in the next few years. The problem is, despite all this, our treatments remain ineffective, and so where do we integrate Hipec into these types of approaches? So as a medical oncologist, I pray at the altar of the randomized controlled clinical trial, okay? People always ask me, do you believe in this or do you believe in that? I tell people that, medicine shouldn't be a religion. I actually am a person of faith. I keep that here and I keep the scientific part over here. With randomized clinical trials, that gives you so-called level 1 evidence, and that's unequivocal. That's basically, you have a large clinical trial, you prove this treatment versus that treatment, this treatment's better, this is the winner, this is our new standard of care. You can have a small clinical trial like that, and it may not be the standard of care. The point is, they're not always possible to do these trials. I mean, if you talk to a person who has, 20 years ago, who has pseudomyxoma, and you tell them I'm going to flip a coin and I'm going to give you the best chemotherapy versus proceeding with this surgery, or I'm going to take it all out of you. It's not somebody who's going to sign up for that kind of a trial very often, and it's probably not an ethical approach in a situation where the best systemic therapy is there is no systemic therapy in that case. So clearly that's the case. And randomized trials and level 1 evidence is not available for a lot of things that we do in medicine. And we accept a lot of that and understand that it's not always going to be possible. But at the same time, if you have a treatment that you think is really good and you should be applying it, I think it's reasonable to do that, but you always have to have an element of skepticism or caution in saying that in fact, this is the absolute best thing. And so, not to say that we shouldn't do it, I'm just saying that we have to keep that in mind. So again, science is not a religion. Interventions are either helpful or not, but sometimes we are just not able to tell the difference between those, and that's the issue. So I think rigidity in both directions in the face of this degree of uncertainty is really not helpful for anything. So I think we have to be honest with ourselves, and I think we have to think about these things. I'm just going to throw some other examples from medical care out there to give you some things that I've learned from over the years. So adjuvant chemotherapy for colon cancer. Up until the time I actually became an attending physician in oncology, there was no data that giving chemotherapy after surgery for stage 2 or stage 3 colon cancer made a difference. The first trial showed a benefit in 1989. That was not for lack of trying. There were probably 15 years of randomized phase 3 trials that went on. Finally, that trial showed that 5-FU-levamisole, which, believe it or not, was a drug that was originally used to deworm sheep, is now was showing a difference in survival. Currently, our treatment is a combination either called Folfox or Zelox, and it's given for 6 months. And we're currently doing a big trial worldwide to see whether or not we can shorten it for 3 months. And we're also using a drug called celecoxib, which is an anti-inflammatory drug which may help as well. Now again, if you think about what we have to do this trial, this is 10,000 patients being done worldwide to show a difference that might be an equal study, which actually it's a very important study. It doesn't sound all that exciting. We're giving the same treatment. We don't expect better results, but the reality is that if we can cut the treatment down by 3 months, we're going to end up resulting in a huge public health savings. I mean, we're going to give 3 months less chemotherapy, we're going to give 3 months less toxicity, and if we can do that as the new standard of care, that's a really important thing. So that's the kind of trial that we accomplish as medical oncologists. But the problem is that we've also fooled ourselves a lot of times, okay? So one of my most productive academic papers was a trial that didn't work. So it was basically a drug called irinotecan was the hot thing for colon cancer in the 90s. And after that drug came along and showed a survival advantage for people who had metastatic colon cancer when it was added to 5-FU, we said, well, this must work for adjuvant treatment. And right away, people, including myself, occasionally would treat patients outside of a study with that combination. Well, we finally got around to doing the big study. Turns out it was a bust. And in fact, we probably harmed more people than we helped. There were actually more toxicities associated with that. We also have new drugs for colon cancer for stage 4 disease, which include bevacizumab, cetuximab, drugs that are very effective in that setting. We were sure that they were going to further improve our stage 3 outcomes. And unfortunately, when we added them to the same kind of adjuvant treatment, we have resounding failures in the adjuvant setting. None of those drugs really made an impact on survival. Again, all at a cost. I mean, not just about financial cost, but these drugs do make people potentially sick. You know, there are perforations associated with the use of bevacizumab. There's a severe skin rash we see with cetuximab. There's pulmonary toxicity. So we do things to people that certainly can affect them negatively. And when we jump to making a conclusion in this setting that we think is going to be the right answer, it is not always. And so we have to be honest with ourselves. Other things, just a couple other things, and then I'm going to go on to the rest of the talk here. But high-dose chemotherapy and stem cell transplant for breast cancer. In the 90s, it became a very accepted approach, even though there's no data. There were ultimately 5 randomized clinical trials that were done. 4 of them were negative. One was positive with a notorious guy named Wisboda, who is from South Africa. It turns out that he falsified his data, and that's the only reason it was positive. And when that was looked at, it turned out that this too was a bust. So again, you know, the difficulty is when you have small studies, you have selection bias, you have cross-trial comparison, you're always comparing it to how things happened in the past. There's too many variables, and we have to be careful about not making conclusions that really aren't validated in that regard. Nevertheless, okay, there are clearly lessons to be learned from clinical information outside of clinical trials. So for example, resection of liver metastases and colon cancer. Long-term survivors exist. We see these people every day. Dr. Sugarbaker, Dr. Salty, myself, all the medical oncologists in the audience. We have people who are alive and are clearly cured as a result of the fact that they've had resection of metastases from colon cancer to their liver. There is no strict randomized clinical controlled trial data that's ever proven that. So no one has ever really done a study with the flip of the coin, and this person gets it, this person doesn't. One other aspect to that is that we often will give chemotherapy to shrink these liver metastases and maybe make them operable in that case. And there was a trial from Europe that suggested giving chemotherapy before and after surgery improves survival. Well, with longer follow-up, that trial has turned negative. There is no real survival advantage. But it's interesting that the people who wrote the final paper on that still said that despite that, we still recommend it. And so, you know, the problem, there's a progression-free survival advantage, there's no survival advantage, and there's a difference between those two. For the medical people in the audience, they're aware of that, but for the non-medical people, the bottom line is still survival. Progression-free survival is a valuable thing. It's certainly good to be alive with no cancer for a while, but if it still comes back, that's still a problem. This is a report of just a total of experience of liver resection. The only reason I put this slide up here, this is from Memorial Sloan Kettering, looking at their experience up until 1994. So this is old data. But the key thing is that you see a flat line on this curve. So down here, there's a little over 20% long-term survivors. It looks like people who make it to this point, if they run the gauntlet for years 1 to 10, they're eventually going to hit a point where there is no further recurrence, and that's what we would call a cure at this point. So flat lines on a curve is what we really would like to see. So again, this is the study I was talking about where they gave chemotherapy before and after removal of those liver metastases. And really, ultimately, the long-term survival with about 10-year follow-up doesn't show a definite improvement to the use of chemotherapy, but again, it's still recommended by the authors. What else do we do? For example, in colon cancer, we also have seen long-term cures in people who have retroperitoneal metastases. So if you have a few lymph nodes, if you have most of your disease has been resected, and it either is present in a couple of lymph nodes that aren't removable on the back wall of the abdomen, or disease comes back on the back wall of the abdomen, there are certainly patients who have been cured by applying other therapies to that site, for example, radiation therapy. And clearly, there is no randomized trial that has proven that that's really the way to go. Do we treat people this way? You bet we do. We're always hopeful when we see a person who has only 1 or 2 retroperitoneal nodes after a long period of freedom from disease that we may be able to have a long-term survivor if we're aggressive in that area. And do I have such survivors in my clinic? Absolutely. I don't think there's ever going to be a randomized controlled trial that's going to help us in that regard, too. What about Hipec in colon cancer? Some of the information has been presented by Dr. Sugarbaker and Salty. I don't know if you're going to have any other data in your talk, George, but I have a little bit in there. There's one randomized controlled trial that Dr. Sugarbaker has referred to from Europe. It's small and relatively underpowered, but it's strongly positive, and that's led to the Netherlands group, I think, making that the standard of care in their country, definitely. There are many series with historical controls. I will say that, you know, I've sent patients for Hipec for probably 20 years. The morbidity of the treatment has improved tremendously. I think that the big thing that we always worried about was, you know, multiple fistulas, multiple bowel obstructions. Those things still happen, but the frequency with which they happen now, certainly the surgical techniques have tremendously improved over that period of time. And I think that as a result, anytime you're thinking of a cost-benefit ratio, it certainly helps when the cost physically to the patient is dramatically less, too. We also know as medical oncologists that when we see patients who have peritoneal metastases, we think about different patterns of metastases. Colon cancer, I'm focusing on that a little more than appendiceal and pseudomyxoma, and we'll talk briefly about the other two. But the point is that there are a lot more colon cancer patients out there, and they have a lot more variable disease. So we're talking about a disease that, yes, goes to the peritoneal cavity, but yes, it goes to the liver, it goes to the lung, it goes to rarely now that people are living longer, we're seeing it go to bone and brain. And so my point is that we know that people who've had peritoneal disease as their sole site of metastases often do have a worse prognosis with our systemic treatments. We've all known that for quite a while. The data has been pretty strong in that regard. So do I send these patients for Hipec? Yes, I certainly do. Whom do I consider? Well, first of all, this is I showed you that liver resection data. This is also older data from 2010 from Dr. Elias. And this is their experience over the years with Hipec for peritoneal carcinomatosis of colorectal origin. And I'm going to show you some good and some bad in this curve, okay? So clearly, the disease-free survival curve is the blue one. So this is basically what percentage of people continue to have no evidence of recurrence. And that drops relatively rapidly. But there is a small number of patients who may be achieving that elusive flat line that we're getting to. But if you look also at overall survival, that's also fairly good. I mean, colon cancer is a disease in which the median survival with the best systemic therapy, with everything being optimal, is currently 24 to 30 months. And so we're not talking about generally keeping people alive for 5 years. We all have occasional patients. I have a patient who went 8 years with metastatic disease at different sites. But the reality is that these are pretty good numbers. And what we don't know is how much systemic therapy they had as a mix of all of this. I'm sure that in general, it was integrated into virtually all these people's care in one way, shape, or form. Not quite as good a numbers as we see with hepatic resection, but certainly better than you would expect with peritoneal disease alone in a historical sense, okay? So when do I consider Hipec in colorectal cancer patients? I do it in patients who really have truly peritoneal avid disease. I mean, clearly, the more sites extra peritoneal that we have, the less I'm going to be considering this as a potential for these patients. Secondly, I think that for any surgical intervention, the more indolent a disease is, the more we're likely to see a benefit. We see that in other cancers that we operate on. If you have, I think pseudomyxoma is a perfect example of that. That's the complete end of the spectrum where you have a very slow-growing tumor. And in fact, oops, I lost my screen here. I don't know if anybody can help me if Jamie's around or somebody can help me with the screen. Yeah, there we go, thanks. So, oops, let me go back up. So I need somebody to be in good shape. Clearly, good performance status, and the surgeons are always the first advocates for this. Somebody's got to be a reasonable candidate for this kind of approach. When I say relatively chemo-naive, I'm talking about people who've had a modest amount of systemic chemotherapy. If you've had 4 prior regimens and you've had multiple recurrences, that's probably the bulkier the disease, the more resistant to the disease, the less likely you're going to have impact with what's a big procedure for people. Do I expect a cure? My answer is probably not, and I tell that to people who I'm going to send for that. Do I get a cure? And I think you might, and I think the question is, in whom do you get those? And I think that's where the data from these registries is helpful, because you can really hone down on who is going to be the big beneficiary in these settings. So pseudomyxoma, that's really the poster child for this procedure. It has kind of the perfect storm of features that favor the use of Hipec. It's slow growing, and surgery is always going to have a bigger impact. It typically lacks metastases to viscera or to nodes. And really, we do terribly with this disease. I mean, oncology, medical oncology adds very little, I think, in general to the management of this disease. So clearly, do I send patients for this? Absolutely. And in fact, this is the one thing in whom everyone really agrees that Doctors Sugarbaker and Salty should be on the front lines of managing these people. Appendiceal carcinoma. I think, I've been doing this for a long time. I still don't quite understand appendiceal carcinoma. It's halfway between colon cancer and pseudomyxoma. It's somewhere in the middle, and they're not all the same. I think there's a huge heterogeneity among the way that appendiceal carcinomas behave. You get low-grade mucinous carcinomas that still have a high cellular burden that are clearly not pseudomyxomas, and then you get higher-grade cancers that are much more like colon cancer, and you get every part of the spectrum in between. They have a much stronger avidity for peritoneal progression than other sites. They're certainly more aggressive and high grade than pseudomyxomas. They're somewhat chemotherapy responsive, though certainly we're not superstars in managing that. And I think Hipec is, in fact, still the best consideration for these patients. But I do think that there is some role for chemotherapy, and we don't for sure know how to integrate that. I mean, most of these patients are going to get FOLFOX from somebody somewhere. Is it before or after? So I just had a patient with a localized perforation that was stuck to the abdominal wall. That patient saw Dr. Salty, or actually I ran it by Dr. Salty. That patient also saw Sam Pappas, who's another Hipec surgeon in the Chicago area. And one recommended doing the procedure up front, the other recommended chemotherapy followed by the procedure. And the issue is, I don't know that anybody knows for sure what's the best way to do that. And so that's the difficulty. And that's where you really need kind of people who are experienced to do this, because until we get better data, that's what we're stuck with. I mean, when you go to the experts, they're experts only because they see rare conditions all the time. And, you know, in the lack of randomized controlled data, sometimes the best you have is opinion. And honestly, I tell people it's our opinion that we do it this way. What about gastric cancer? Well, gastric cancer is done sometimes. It is highly variable clinically. I mean, it's a disease that we have really still not understood very well molecularly. Now there are more and more subdividing going on in terms of the nature of the gastric cancer, but we've clinically known that these cancers behave completely differently. So you can have a diffuse gastric carcinoma with rapid peritoneal spread, highly aggressive, typical linitis plastica. These patients generally are not going to benefit largely by many of our approaches, whether they be chemotherapy, surgery, or even intraperitoneal chemotherapy. However, there are other diffuse gastric cancers that have really a slow behavior. I mean, there are people who recur 7 years later sometimes with what looks like peritoneal disease, and that might be a candidate for an approach like this. And then there are also the more typical bulky gastric cancers that have a lot of visceral metastases. Those are not the people who really should be approached with a Hipec procedure. So do I send them for this? Rarely. I do, but not very often. And often other considerations stand in the way. If somebody's had a gastric resection in the past and they have difficulty with weight loss and poor performance status, sometimes it's not somebody who's in the shape they need to be to do that. Certainly if they have other visceral disease and rapidly aggressive disease, it's probably not in their best interest to do that. What about peritoneal sarcomatosis? Well, my colleague, I don't know if Samir is here, I don't think so, but Dr. Indevia in our group, we're fortunate to have a real sarcoma expert in our group. And we're very happy to have him because we don't know how to manage it. And anytime we have a sarcoma patient, we give them to Samir. But the reality is that most sarcomas have few effective therapies. We're starting to see a few emerge. But clearly, I think that surgery plays a role in this disease. Certainly for low-grade sarcomas in the abdomen and other settings, it does. For sarcomatosis, I don't have anything better to offer, and I certainly think if somebody's in good shape, it's a strong consideration. So I think that that's something that I leave to those experts, and I think that that's a consideration in almost all those cases. Peritoneal mesothelioma. Again, our chemotherapy agents are a little better than they used to be. We have platinum agents, we have pemetrexed, and recent data on bevacizumab, which is in pleural mesothelioma, and the question is whether that'll translate to peritoneal mesothelioma. But the impact of our drugs on their lifespan is measured in months. We're not talking about by itself medical oncology making a huge impact. So in general, we definitely think that there's a benefit from Hipec in this subgroup of patients, and we do refer these patients, absolutely. Ovarian cancer. So this is an interesting population. So I don't like to get into the arguments between the gynecologic surgeons and the surgical oncologists on this one, but I usually try to talk to each one of them individually in a room and not go into a room where they're both present usually. But there are a lot of randomized trials in ovarian cancer. All of these have been generally done through gynecologic groups. The GOG is famous for this. Dr. Sugarbaker mentioned Deb Armstrong's trial looking at intraperitoneal chemotherapy, which is the GOG 172 trial. And clearly they show a survival advantage. There's no question intraperitoneal chemotherapy has a survival advantage. The difficulty we've had is with the methodology that was put forth in those studies. It's really hard to do. And even in the National Comprehensive Cancer Center Network, which is 32 of the top cancer centers in the country, only 40% of patients get that type of therapy as part of their standard treatment. And so in the community, you can imagine it's even less. We do it rarely. So Do I know best how to integrate Hipec? It seems like that'd be a great way to do the treatment intraperitoneally at the same time and integrate it with systemic chemotherapy. We're proposing actually a trial that we were talking about writing here. Matt's probably back in the audience somewhere, but I'm going to ask him to help us with that. But the fact is we'd like to do a trial of Hipec with dose-dense carbotaxol and see if, do a small phase 2 study and at least look at the feasibility and safety of that approach. And I'm sure there are other people doing the same thing, and Dr. Sugarbaker can enlighten me about more of those, I'm sure. So that's typically what I have done. We certainly need more data in that setting as well. So what are my conclusions? Again, it's more, like I said, it's more a conceptual trial than a data-driven trial, but am I glad to have this available at our institution? Absolutely. There's no question about it. I mean, I've sent patients for Hipec. I'm glad to not have to send them to St. Louis, to Pittsburgh, to the other places in the area. I mean, there were very few people who were doing it in the Midwest for a while. Do I believe all the claims made for its benefit? No, because I'm a natural-born skeptic. I have faith, but it's in other areas. So, but I do believe there is real benefit for patients. There's no question about it. Will I ever have level 1 evidence? Dr. Sugarbaker mentioned trials that he knows about that I don't, so maybe I will. But so far I don't know that I have it. Does that mean I wouldn't do it? No. Do I see it as a tolerable procedure in many cases? Yes. But really, patient selection is the key, as in all things surgical. And I think in general, I think that we need, as medical oncologists, to think a little bit outside the box. That's what we're guilty of. We're very rigid sometimes. And it's inculcated into us all through our training, which is helpful. But sometimes we have to think outside the box. Do I think that we can carefully use what's been learned to select patients for benefit? Yeah, that's what the registries are for. They have their limits. The data is only so good. So keep it in mind. Is it a solution for everything? No. Have I drunk the Kool-Aid on Hipec? I'll leave it for you guys to decide. All right. Thank you.